Good morning again. It's always a sign of a good conference when it takes a while for everybody to settle back in and put a pause on the visiting. So, if I can please have your attention, we're going to get rolling here again. And I know we have a few people that are still possibly making their way just through the consent or the clinic. And again, just a reminder, the interactive research clinic is open until 4 p.m. today. So even after we finish today, lots of opportunity and time to go through those stations. Our next speaker is Dr. Robert Laprairie. And he is an assistant professor and conducts his research at the University of Saskatchewan. His laboratory is currently working to increase understanding of marijuana as medicine and possibly the development of new drug compounds. We know this is certainly a hot topic as with the recent legalization, and we're really looking forward to learning more about this alternative therapy. Please welcome Dr. Laprairie to the podium.
All right. Good morning. Can everyone hear me at the back? Yes? I see a thumbs up right at the back, so we're set. So today I'm going to talk about what I call Cannabis 101 or Cannabinoids 101. We're going to spend a fair bit of time just doing background. Don't be intimidated if I show you guys a lot of data or graphs or anything like that. More than anything, it's meant as a mental cue for myself for what to talk about next. And the good news for y'all is that there's no test at the end of this. So just by way of disclosure, I like to get these things out of the way first whenever I talk. So I do have research grant support from a number of national and local funding bodies, including CIHR and SHRF, as well as NSERC. And I've received speaking honoraria from a number of groups. And I am receiving legal fees for consultation on ongoing proceedings and challenges related to the legalization of cannabis. This presentation receives no support financially from any organization, and I have no other conflicts of interest to declare. And then finally, some of my research is actually supported by a collaborative grant between the federal government and Cannabis Therapeutics. That's ongoing research that's supported in a peer-reviewed process. And then most importantly, thank you guys for your attention this morning, for coming out, and thank you to the organizers of this meeting for really just putting on a great event. And I personally really love that research is being actively included as part of this. I think that's an excellent idea. So, recently cannabis was legalized in Canada, and we had a very prestigious Twitter person put up their comments about how popular that cannabis legalization was going to be. And cannabis has been in the news a lot lately. There's a lot of open-ended questions about it. Canada has now legalized cannabis for both medicinal and recreational purposes, but there's still really a lack of understanding or perception about what it is, where it's useful, and where it is not. So this morning I'm going to take the little bit of time that I do have with you and just talk about what a cannabinoid is, how your body's own cannabinoid system works, or what I call the endocannabinoid system, cannabinoids as drugs, and specifically here this morning in the context of MS. And then I'm going to talk a little bit, just a little bit, about the research that my lab group is doing because I'm really excited about it, and the broader context of cannabis research here in Saskatchewan through the Cannabis Research Initiative of Saskatchewan, or CRIS. So here's what I hope we get out of this morning. First, I want to talk to you guys about the ABCs of THC. Then we're going to recognize where and when cannabinoids play an important role in the body and summarize the history of cannabinoid research to date. We're going to talk a little bit about the evidence base for cannabis as medicine, where it is and where it is not, and how we need to think critically about that evidence and what strengths and weaknesses it might have. And I'll touch a little bit on the history of Canadian cannabis legalization. So I like to start off with this graph. This graph shows the increasing popularity of cannabinoid research globally. So on the y-axis, we're showing the number of papers that are published every year in this field. And you can see that since about 1995, the number of scientific papers has increased dramatically. Now, the other important thing that I want to point out with this paper is just how new this field is. Historically, it's been challenging to conduct research related to cannabis because of either the legal parameters or just the challenges associated with the science itself. So it wasn't until 1964 when an Israeli chemist named Raphael Meshulam worked out what the thing was in cannabis that actually got people high, and that's THC. So that happened in 1964. By comparison, we've known how opium poppies produce morphine since at least the early 1800s. And then it wasn't until 1991 that we actually figured out that the human body has a receptor that responds to both naturally occurring cannabinoids in your own body as well as plant cannabinoids. And then most recently, it wasn't until last year that researchers were able to figure out what the human receptor looked like. So that's the crystal structure of CB1, or the type 1 cannabinoid receptor. That happened last year. When we look at other fields of pharmacological research, this puts cannabinoid research at about a 20-year lag compared to other fields. So, I'd like to start off with this question. How many people here, just by show of hands, this is about as anonymous as we can get, have been curious about cannabis use either for themselves, their patients, their clients, any of that, just by show of hands? Right, so most of us, probably. And then, as part of your education or your formal training, how many people learned about how cannabinoids work? 1, 2, 3, 4. 4 people. So that's a significant knowledge gap that we need to address as a society, because this is now something that's widely available, and it's something we need to understand as people. So what's a cannabinoid? So very broadly speaking, a cannabinoid is any chemical that is structurally or functionally related to THC. These come in 3 flavors, as I like to describe them. Hello? Endogenous cannabinoids, which are cannabinoids that our body is synthesizing all the time, and I'll get into those in a couple of slides. Phytocannabinoids, or plant cannabinoids, that the plant Cannabis sativa produces, as well as synthetic cannabinoids. Synthetic cannabinoids were traditionally made by medicinal chemists that were trying to understand the endocannabinoid system. They were used as tool compounds. Today, unfortunately, they're also seen as drugs of abuse, and you might see them come up in the news as K2 or spice, and they're recognized now as substance use problems. To date, we have identified at least, if not more, 120 different plant-based cannabinoids. The 2 major ones are THC and cannabidiol, which we sometimes refer to as CBD. The other 118 we know almost nothing about, and we'll talk about that in a little bit too. So, your body's endocannabinoid system. Your body has a series of neurotransmitters called endocannabinoids. The 2 major ones are called anandamide, or AEA, and 2AG. In this diagram, I'm showing 2 neurons talking to one another across a synapse. The blue neuron is your presynaptic neuron. It's the neuron that's going to send the initial signal. And the pink neuron is your postsynaptic neuron, and it's the neuron that's going to receive the signal. So when your presynaptic neuron releases neurotransmitter, shown in the little blue bubbles, that's going to cross the synaptic cleft, and it's going to activate the postsynaptic neuron. When that happens, the postsynaptic neuron is going to synthesize your endogenous cannabinoids on demand, and they're going to travel backwards, or in a retrograde direction, to the first neuron and tell that neuron to slow down. They're going to tell that neuron to stop releasing more neurotransmitter. And in this way, your endocannabinoids are acting like a synaptic braking mechanism. They're telling things, slow down, release less neurotransmitter, we're good here. And the way they accomplish that is by activating your type 1 cannabinoid receptor, or CB1. Now, you also have another complement of cannabinoid receptors. It's called CB2. CB2 is mostly expressed on immune cells, glia. These are the immune cells that modulate inflammation, And when CB2 gets activated, it tells those immune cells to reduce inflammation. They are anti-inflammatory in their effect. So already we can see how cannabinoids are modulating neurotransmission, and we can see how cannabinoids limit inflammation. So here are some of the examples of the different cannabinoids. Hello. My mic is a little bit jumpy this afternoon. Light is on. Light. On the far left, those are your endogenous cannabinoids. They are lipids. These are fat soluble. Thank you. Oh. So I might be a little bit louder right now. And if I turn my head to the side and you hear my beard brushing the microphone, that's what's going on there. So hopefully, can everyone hear me now with this system? Great, thank you. In the middle, we have our plant cannabinoids, or our phytocannabinoids. And the two major ones, again, that's the CBD and the THC. And then we have our synthetic cannabinoids. These are things like WIN and CP55940. Again, mostly tool compounds to study how cannabinoids work. What I want to stress here is the difference between CBD and THC. So cannabidiol, it has a number of different actions in the body. One of those is to indirectly inhibit CB1. This is acting as a negative allosteric modulator, so indirect inhibition. But it also modulates a number of other receptors that we'll talk about later. THC is a partial agonist of CB1 and CB2. What this means is that THC turns on those receptors. In particular, when you activate CB1, that's where psychoactivity and intoxication comes from. So THC activates CB1, and that's what gets you high. Cannabidiol does not activate CB1 and does not produce a high. Where are these receptors? CB1 is the most abundant G protein coupled receptor, that's the receptor family it belongs to, that you have in your brain. You have more CB1 in your brain right now than you have dopamine, serotonin, and opioid receptors combined. CB1 is expressed at the highest levels in areas of the brain that are responsible for the regulation of voluntary movement, effects on memory, appetite, and pain perception. And that links up with a lot of the effects that we know to be true of cannabinoids. So they affect our voluntary movement, they affect our appetite, they affect our pain perception, and they affect our memory. CB2, in contrast, is expressed again mostly on immune cells that modulate our inflammatory response. But where and when CB1 is by no means static, and it changes over the life cycle of a person. So you'll remember a few slides ago, I was talking about how CB1 limits neurotransmitter release. It's this neuronal braking mechanism. Well, one of the things that chronic or long-term activation of CB1 does is it helps the brain to decide which synapses or connections between neurons should form and which should not. So it plays an important role in the architecture of your brain. In your early and late embryonic development, when we were all babies, this meant that CB1 was expressed at super high levels, and it was helping your brain to decide which synapses ought to form and which synapses ought not form. As we age, that distribution of CB1 receptors shifts over time and becomes more concentrated in areas of the brain that continue to develop. One of those areas is the prefrontal cortex. The prefrontal cortex is this part of the brain that's right at the front, right here, and it's really important for executive function or higher decision making. So for example, as a teenager, when your executive function part of your brain hasn't finished forming, that's the part of your brain that ought to tell you, don't jump off your friend's garage roof into the pool because that will be bad. But it hasn't stopped forming, it hasn't finished forming yet, it's not done its work. And so CB1 continues to be active in that area. Just by frame of reference, our adolescence doesn't stop neurologically until we're about 25 years old, okay? In adulthood, we continue to see a change or a shift in expression of CB1, now more highly localized into areas of the brain responsible for mood processes, as well as movement and appetite. So what are those key physiological roles, just to summarize again? So CB1, that's critical for memory, voluntary movement, stress and anxiety, appetite and metabolism, and temperature regulation. CB2 is critical for inflammation. And CB1 and CB2, together are critical for our pain perception. All right, so I'm going to now summarize a few of the different plant-based cannabinoids. THC, or delta-9 tetrahydrocannabinol, is the most abundant cannabinoid in many, but not all, different cannabis strains or cultivars. Like I said earlier, it is a partial agonist of CB1 and CB2. That means it turns those receptors on. It is psychoactive and intoxicating, and you'll see why this is important in a couple of slides. And what that means is that it acts in the brain and it produces intoxication. And it does the classic high things. So you get euphoria, delirium, delayed reaction time, etc. THC might have clinical utility in cases such as cachexia in late-stage chemotherapy patients who need their appetite stimulated. It might have utility in spasticity in MS, and we'll talk more about that in a few slides. It might also have use in opioid sparing and in pain. When we talk about THC, it's important to recognize that, like any other drug, it is itself a drug. When it is inhaled into the body, it is rapidly absorbed into the blood and then sent out to fat-rich tissues in the body, like the fat itself and the brain. And typically, we see a spike in blood levels within 30 minutes and then a decrease in blood levels very rapidly after that. When THC is orally ingested, we see a delay before THC gets into the blood and the brain. When we think kind of anecdotally about our different stories that we might have heard for people ingesting edible cannabinoids or cannabis, these are the people who will eat one and say, oh, that didn't do anything. And then they'll eat another one and another one and another one, and then they get into trouble. And the reason for that is that there's a delay between when you ingest and the onset of action. Something else that happens with these cannabinoids is that they're metabolized. THC is initially metabolized into a compound called 11-hydroxy-THC. And 11-hydroxy-THC is also intoxicating. Now, this is a drug like any other, and that means it's being metabolized in the liver like a lot of your other drugs. That means that there could be important drug-drug interactions between the medications you're already taking and the cannabinoids. And it's important to consult with someone like a pharmacist who would be able to tell you specifically, these are the drugs I'm taking, and this is THC. Is there an interaction that I should think about? The last piece I want to talk about specifically related to THC is use and abuse. So THC itself is an addictive substance. Among the general population of people who use cannabis daily, we see that the addiction rate for THC and cannabis is about 9% of the population. This is more prevalent in adolescents, and it's more prevalent in individuals who have other mental health impairments and other people who have other substance use disorders, whether that's gambling or tobacco use or ethanol use. What about cannabidiol, the other plant cannabinoid? So this is often, but not always, the second most abundant cannabinoid in cannabis. It is psychoactive, which means it works in the brain, but it is not intoxicating. Cannabidiol has a host of different receptor targets in the brain that it works on. Not just cannabinoid receptors, but serotonin receptors, opioid receptors, and the list goes on and on. We don't know in the body exactly how cannabidiol works, but there are certain conditions where it does seem to work, and I'll talk about those right away. One of the clearest ones is this example in epilepsy. So cannabidiol consistently displays clinical utility in a number of conditions, including as an anti-inflammatory agent, an antioxidant, an anxiolytic, and an anticonvulsant. However, I want to stress that this is animal model research, not clinical evidence, and we'll get into the clinical evidence soon. In this complicated diagram, all I'm trying to communicate is in all animal studies tested to date, Cannabidiol itself has shown consistent and robust anticonvulsant activity, which means that it is acting to reduce seizure number in animal models. What about these other cannabinoids, some of the other 118 cannabinoids that are present in the plant? Well, these are two examples. This is THCV and CBDV. We think that they might be acting at some of the cannabinoid receptors, either as agonists, which turn the receptor on, or as antagonists, which block the receptor's effects. And these two compounds may display some anticonvulsant or anti-seizure activity in animal models. But these studies are really only based on 1 or 2 scientific papers, and we need a lot more research in this area. 2 other compounds, cannabigerol and cannabichromene. Again, they seem to have some effects at the cannabinoid receptors and some other receptors, but really we only have 1 or 2 papers to go on for this information, and we need more research. And then there's this compound. So a lot of people will ask me about terpenes. Terpenes are something that are in the news a lot lately related to cannabis. They're the compounds in any plant, not just cannabis, that give the plant a lot of its signature smells. So when we walk through a pine forest, what we're actually smelling is a compound called alpha-pinene, and that gives off that great pine aroma. One of the terpenes present in cannabis, and also in rhododendrons, is this compound called beta-caryophyllene. Beta-caryophyllene actually seems to be a CB2 agonist, so it turns on CB2 and may have really potent anti-inflammatory effects. When this evidence was first released in 2008, there was a flood of patents that people tried to file to get their hands on how beta-caryophyllene might work and how it might be an effective anti-inflammatory drug. So in any environment where you have a complex mixture of different drugs, for example, cannabis, one of the questions we have to ask is the combination of those chemicals meaningful? And in the cannabis research world, we've dubbed this the entourage effect. So is there an effect of having this complex mixture of cannabinoids? This becomes critically important because if we try to compare between studies that are not using the same plant material, we cannot say that those studies use the same drug. Some of the questions we need to ask are, does this complex mixture interact? And if so, are those interactions beneficial? Are they harmful? Do they not matter at all? Are they synergistic? And how do we study them as scientists that have almost always taken a reductionist approach to doing research? And how reliable are those interactions? Again, if I'm doing a study here in Saskatoon with Dr. Levin, and we're looking at one plant mixture, is another study happening in Winnipeg looking at a different plant mixture going to find completely opposing results because we're using different drugs? And that leads me into the progression of thought and the legal status of cannabis in Canada. So, cannabis was first banned in Canada in 1923. And it was seen as this horrible, terrible thing, and there was a lot of propaganda related to it. It was regulated by Health Canada under the Controlled Drugs and Substances Act in the same way that we control and regulate heroin. In 1972, a commission in Ottawa called the Ledane Commission stated that cannabis should be decriminalized. So not legal, difference there, but decriminalized, because the Ledane Commission felt that the incarceration of individuals who held and possessed cannabis was putting an undue strain on the legal system. In 2001, legislation was made possible through the Marijuana Medical Access Regulations that allowed for a single government-sponsored entity to sell cannabis-based medicines to individuals who had authorized use from a physician. That then evolved into what became known as the Marijuana for Medical Purposes Regulation, or the MMPR. Some of you might be wondering why I put the Mighty Morphin Power Rangers there. If you Google MMPR, you will have to search through 2 pages of Mighty Morphin Power Rangers before you get to what you want. Unless you want the Power Rangers, that's fine too. So the MMPR allowed for licensed applications for both personal, in-home, and commercial growth from other licensed producers, and it was later amended the following year to allow for the sale of oils and non-dried plant products. And then finally, in 2016, these legislators were further updated into the ACMPR, and this allowed for greater freedom for personal cultivation, a transition into one day becoming a fully legalized entity, which is where we are today, and a Schedule II drug rather than a narcotic. What do we look like right now here in Canada? So, the Liberal government has announced that cannabis will be officially legalized at some point in 2018, and here we are now as of October 17th of 2018, and that is the case. The federal government decided that each province should be allowed to dictate what that program looks like within the context of its own borders. And so right now we have 10 provinces and 3 territories that are acting like little incubators, and in 5 years' time we'll see who got the model right and who got the model wrong and what all the in-betweens are. For the most part, provinces set an age of legal use to match their drinking age. And this is still an evolving concept in Quebec. And many provinces, but not all provinces, went with a retail-based model, which is what we did here in Saskatchewan. A couple of other provinces, most notably Nova Scotia, New Brunswick, and PEI, went with a Crown Corporation model whereby either the Liquor Board or a new Crown Corporation will be responsible for the sale of cannabis. Here in Saskatoon, you are not allowed to use cannabis in public or in vehicles. You can gift it, but you can't sell it if you're a private citizen. And you can only transport it if it's contained within its original packaging, sealed, and preferably in the trunk. So now I'm going to switch over and talk to you guys a little bit about the research that's going on in my lab. Now, my lab has evolved since I took this picture, and I've got several new faces, some of whom were gracious enough to join me here today and actually spend their Saturday with us, which is really awesome. Research is very much a team sport, and so I'm really appreciative of all the people that do this hard work. So in the past, the research in my lab has been focused on understanding how cannabinoids as drugs bind to the receptor, how we can understand that interaction, and how we might be able to exploit it to produce better and more interesting drugs. This has included studying the mechanism of action for cannabidiol, as well as understanding how different drugs might force the signaling of cannabinoid receptors one way or another in an effort to reduce side effects. One of the projects that I'm really excited about is understanding these lesser-known phytocannabinoids. So I dropped a hint earlier that there's a whole bunch of other cannabinoids in the plant that we know relatively little about. One of our research programs is to actively determine what those phytocannabinoids do, where they might be useful, and where they might not be useful. Another program that we have on the go is investigating these synthetic cannabinoids that I call positive allosteric modulators. So these are synthetic cannabinoids. They are not from the plant, but rather than the traditional route, what these ligands do is they bind to some other site on the cannabinoid receptor, and in doing so, turn the receptor's dimmer switch up to 11 for the endogenous cannabinoid. So they're promoting the endogenous cannabinoid's action, but not themselves affecting the receptor. So this is hopefully enhancing your body's own cannabinoid system without themselves producing the intoxicating or high effects that we associate with cannabinoids. And we're actively applying these drugs to different indications. One of those indications is pediatric epilepsy, where we're looking at these drugs as a potential treatment for pediatric absence epilepsy, and we're seeing some pretty cool results there. So now I'm going to shift gears yet again. I know I'm covering a lot of space, but I have a lot of passion for this, and I want to be as comprehensive as possible. I'm going to talk now about cannabinoids as drugs. So if you go on Google right now today, and you Google cannabis plus insert disease name here, you will find information telling you that cannabis can treat or cure whatever that blank was. That's not the case, and generally speaking, those information that are out there are probably clinically unfounded, unfortunately. When we look at the rigorous clinical data around cannabis, what we see is that the data tend to be anecdotal, case reports, or they're underpowered, which means that the study sizes were small compared to many other studies done with other drugs. The studies also tend to lack blinding, which means that the investigators and the participants are aware of the drug that they're using. and they tend to include a heterogeneous patient population, more so than other studies. So for example, it might not be useful to lump in someone with osteoarthritic pain and someone with a diabetic neuropathy, because that isn't really the same kind of pain. And finally, there's a real suffering of heterogeneity of route of administration. And what I mean by that is that some studies, they might look at oral ingestion of cannabis. Other studies might look at smoked ingestion of cannabis. Other studies might use topical applications. And you can't necessarily compare all these things, and so it becomes hard to lump them together. This is by no means the fault of the researchers. This is a great place to start, but now that we have access to legalized cannabis and we can explore this in more detail, we need to do better. Also, historically, it's just been difficult to work with cannabis, but like I said, now here in Canada, we have this tremendous opportunity to emerge as a leader in the world in how we do this research. So the first thing I want to talk about is cannabinoids and pain. So this is probably the area where there's the most evidence for cannabinoids as medicine. And if we think back to that earlier slide where I showed you the blue neuron and the pink neuron, all we're doing here is looking at those neurons in the context of the spinal cord, and we're saying that when you activate CB1, you're limiting the release of pain-processing neurotransmitters in the spinal cord. So CB1 gets turned on, less painful stimuli are transmitted from the spinal cord up into the brain. You perceive less pain. CB2 also inhibits inflammation in the periphery, and that's responsible for some of the pain we perceive. So both CB1 and CB2, as well as some of these other receptors, are limiting our perception of pain in the body. Like I said, there's a lot of different types of pain. And sometimes, as researchers, what we try to do to understand the clinical data is we conduct a systematic review, which means we take all the literature that are available and we say, generally speaking, on as wide a scope as possible, is there evidence between studies that this medicine reduces disease X, in this case, pain? In this study, what they've done is conduct a systematic review of systematic reviews. So this is now 2 layers of meta deep. It's a systematic review of systematic reviews. When they looked across 82 randomized clinical control trials, what they observed was that, generally speaking, there was a 30% reduction in pain when different cannabinoids were used. This is a huge blanket statement because the cannabinoids used from study to study varied quite a bit. But they did come up with some conclusions. First, that there is reasonable evidence that cannabis and cannabinoids improve nausea and vomiting in patients that have chemotherapy. Second, that there is some uncertainty about whether or not cannabinoids do truly improve pain in humans. But if they do, it's likely in the context of neuropathic pain, and the benefit is likely small. Adverse effects were common, but not included in this quote. The adverse effects tended to be pretty benign in nature, so things like nausea, indigestion, tiredness, no overdoses were observed. And would need to be considered to warrant, meaning that benefits would need to be considerable in order to warrant further trials of therapy. So with that background in mind, I'm going to move into multiple sclerosis specifically. So as we've talked about, cannabinoids have consistent effects in animal models and in some human studies on effects of movement, mood, inflammation, and pain. When we think about MS, this is an autoimmune demyelinating disease, as we've heard about already this morning, that is characterized by lesions, inflammation, the permeation of the blood-brain barrier, blurred vision, spasm and spasticity, chronic pain, unstable mood, and problems with speech. So if we just think about how cannabinoids work in the body and issues that we observe in multiple sclerosis, it seems logical, at least at face value, that there might be some interplay here. But what do the data show us? Well, there have been numerous animal-level models to suggest the utility of CB1 or CB2 agonists in the context of MS. In the clinic, as of this year, there have been 16 clinical trials that have specifically looked at spasticity in MS and whether or not cannabinoids might be useful. Now, they use a host of different cannabinoid-based medicines. The first was this thing called nabiximols. So nabiximols is a 1-to-1 oral combination of THC and cannabidiol. Nabiximols showed no improvement. THC showed inconsistent results, and smoked cannabis actually worsened balance. Now, what's interesting here is that many of the patients in these studies themselves reported benefit from using cannabis-based medicines. But when objective measures were taken of the patient's balance and function, no improvements were observed. What about central pain and spasm in the context specifically of multiple sclerosis? So nabiximols, again, that one-to-one combo of THC and cannabidiol, showed no improvement or a slight reduction in pain intensity. THC or other combinations of THC and cannabidiol showed about a 30% reduction in pain and spasm, which is pretty good. And smoked cannabis did reduce pain and spasm as well. The conclusion from this, based on this meta-analysis, was that for these patients, some cannabinoids are effective to reduce pain and painful spasm in the context of multiple sclerosis to about 30% relative to baseline, but never as a first-line option. In fact, the current recommendation by the Canadian College of Physicians and Surgeons is that cannabinoids be considered as a third-line option. Sorry, is your hand up back there? Yes. Sure.
Like, the plant, they are different, aren't they? Like, is it an indica plant? Is it a sativa plant? Is it a, like,
Yeah,
it's hard to describe. Like, the plants are very different. Like, for example, one plant I know of is a Penelope plant. It's called Penelope, so it's got a higher THC, like a 5/8.
Sure.
Or a THC to CBD. But then another plant is really high, grown to be high in THC.
Right. So
does that make sense? So I don't know.
Perfect sense.
It's hard to say, like, if they're not smoking the right thing or taking the right amount of drops or whatever with different kinds of plants.
Yeah.
So that's how can you run a study if you, like, you really have to do 5 different kinds of plants because they might do something different to everybody.
Sure. So
Yeah.
what this data are, it's an aggregate lump data of 13 different studies. So they've lumped a bunch of studies together, and each study will have used a different plant material or oil. And so this is one of the weaknesses, generally speaking, of the clinical data, is that we just don't have enough information yet to say with any certainty it's this plant at this dose this often that would give you an effect.
We know that because we've all seen stuff on CNN and things, they talk about a specific plant that they've grown in Colorado for like an oil, like a CBD that they give a child with, I can't think of the name of the epilepsy, that has epilepsy, and they've given her a specific kind of oil from this specific plant that was grown that, like, with a certain amount of CBD properties and THC properties and stuff like that. So I just don't know how they could run a study. The consistency would not be there.
Well, so these are, again, this is 13 different studies, and each of them arrived at their own conclusion. And what the authors of this paper have done is then aggregated that and said, on the whole, when we look at all the evidence for cannabis-based medicine, what we see is a 30% average reduction in pain. Now, each of those individual studies might have arrived at their own conclusions, but what happened, so the case you're referring to is Charlotte's Web, and the patient that had Dravet's syndrome epilepsy, which is a very severe form of epilepsy. When that originally happened, we recognized that this was a specific strain that had a defined content of CBD. What was then done with that is researchers like myself and clinicians took that and ran randomized control trials to try and figure out what dose and frequency and all this sort of thing were needed. So in the case of MS, we're not there yet. We're still in the early, but it'll be exciting to see what happens. Yeah, great point. So then, in addition to the pain and spasticity piece, they've also investigated other different cannabinoids for bladder dysfunction as well as tremor. And what they've seen again as an aggregate score is that nabiximols are effective at reducing bladder dysfunction, whereas THC, so just THC alone, is not. And then in the context of tremor, it seems like most oral cannabis products in THC are ineffective. Right now, today, globally, there are 30 clinical trials that are either ongoing or just wrapped up, but they haven't published their results yet, that are looking at different specific cannabinoid combinations to determine what those dosing requirements might be and how to pair that with an individual's symptoms. So based on this, there are specific guidelines that were just released last month from the American Academy of Neurology on cannabinoids in the context of MS. And I'll just run through some of these with you guys this morning. So for spasticity, these compounds are probably effective at reducing patient-reported symptoms of spasticity in patients with MS. However, oral cannabis extracts and synthetic THC were not found to be effective at reducing physician-administered measures of spasticity. In the context of pain, these compounds are likely to be effective, but again, never as a first-line option. In the context of tremor, they are not found to be effective. And in the context of urinary symptoms, again, the American Neurology Society saying not effective for bladder incontinence. For smoked cannabis specifically, research studies have not produced enough evidence to assess the safety or effectiveness of smoked cannabis for treating MS. So the long-term safety of marijuana for MS symptom management is not yet known, and this is an ongoing study. I'll take your question at the end if that's okay, because I'm just a few slides away. There are a number of adverse effects that have been reported. These vary from diarrhea, nausea, and vomiting, reported in about a third of patients, all the way down to much less common symptoms, including paranoia, which only occurred in about 1 in 500 patients. So this quote, again, directly from the American Neurology Academy, case report and anecdotes still greatly outnumber high-quality studies. High-quality scientific methods and standards need to be applied to the study of cannabis to fully understand their medical potential for use. There is the strongest evidence to indicate benefits in the treatment of muscle spasticity and neuropathic pain. So I want to give you guys a couple of resources before I wrap up here. There are several different educational platforms where information can be accessed by the public. The first of these is called the CCIC Educational Platform. This is brought to you by the Canadian Consortium for Investigators of Cannabinoids. Every year we hold an annual meeting, and all of our talks and slides are publicly available. The Cannabinoid Research Initiative of Saskatchewan also has a website where all of our resources and publications are freely available, as well as the Michael G. DeGroote Center for Cannabis Research at McMaster University. Now, the McMaster site has a lot more information on cannabis use disorder and addiction, but still a helpful resource. And then finally, the Canadian Pharmacists Association hosts several continuing education modules that are available through their website if you want, as a healthcare professional, to access that information and increase your knowledge about cannabinoids. And that brings me to CRIS, or the Cannabinoid Research Initiative of Saskatchewan. So this is an interdisciplinary research group formed here on campus. It's the first of its kind in Canada. And currently we have about 40 faculty members spanning everything from agriculture to law to medicine. Our goal is to be truly from plant to policy. And our scope includes everything from clinical evaluation all the way up through veterinary science and studies of cannabinoids in society. We have a website. If you just Google CRIS Saskatchewan, it'll come right up in Google. And we also have a Wikipedia page, which is pretty exciting. And then finally, last two slides, just want to acknowledge all the funding support that's been able to make the research here in Saskatchewan possible. As Dr. Levin indicated earlier, we have a great collaborative environment here in Saskatchewan where we can approach others from across the hall or across the city and get research going in a way that is truly unique to our province. And thank all the people that contribute to this research every day. And with that, I'll just leave it open to some more questions. Yeah, there was one right there.
Oh, I was just wondering, you're talking, oh, it's not on. Hello?
Hi.
So you were talking about how people report that they have improvement, maybe sometimes significant improvement, but the doctors observing them said that there's no measurable improvement. And I'm wondering, who's better to tell if there's improvement than the actual person? Like, just because they're trying to measure their movement of spasticity, but can't the person tell if their muscles feel tight or jerky or whatever better than some measurement on the outside?
Yeah, so that's a great question, and I confess that I left that in there intentionally to try and spark a question. So who better to tell you that you're feeling good than yourself, right? So it points to, I guess, the divergence between patient-reported outcomes and quantifiable physician-reported outcomes. Both are useful and valuable, and both need to be reported. So I think it's important to note that the study investigators chose to make that distinction, and in their final conclusion in that paper, what they were very explicit in saying is that both of those things matter, and if the patients reported a benefit, then that should be recorded going forward. So, yeah.
My question is there any study or any evidence to show that any of these drugs affect emotional affect, memory, or cognitive functioning, or is that being explored in some way? I understood that there's some impact for dementia, and wondering if there was some link to MS in that regard. I don't know.
So in the explicit context of multiple sclerosis, that has not been a study endpoint that has been assessed to date. But if we look at other studies that were performed that, for example, assessed, like you said, dementia or just generalized anxiety disorder or post-traumatic stress disorder, there are studies that show some level of benefit to reducing anxiety. But however, on the flip side, there have been a number of studies that have reported just the opposite. So I'd say the research field is still too much in its infancy to make any kind of hard and fast statements about those sorts of things.
I know we have a couple more questions, and we want to get to those folks, but we just want to pause for one moment. The Parktown staff are going to be coming around and getting you set up for lunch, because we want to make sure that we keep things moving along. So to the Parktown staff, please feel free to do what you need to do to get our lunch service out. Lunch is plated, so it will come to you. You don't need to go out and wheel or walk over to a buffet line. We'll have time for just maybe a few more questions. And we also, I see you, Patrick. We want to make sure that other folks that haven't had a chance to ask some questions also have some time to do so. So if you need to get up and move around or use the washroom, please feel free to do that. If you're okay to answer maybe 3 more questions, we'll keep that going. So who else had their hand? I know we had 2 in the front. Was there someone else near the back that had a question up before? Okay.
So in regards to your history of research, your dissertation, and you mentioned legalese, so there's voir dire, I'm going to refer you to India. And there's a river there called the Ganges, which is named after Ganja goddess. And the Satyagraha deals with truth. So my question is quite simple. Do you have an Ayurvedic doctor on your team? Do you speak Sanskrit? And have you ever read The Blue Barrel?
I have never read either, but I can tell you that a number of different studies are based out of kind of the early literature that came out of both India and China that were trying to characterize the potential medicinal benefits of this plant. And in kind of a nod to that, one of our endocannabinoids, anandamide, is named after the Sanskrit word for bliss.
Okay, so you know about mom then?
Yeah.
Okay, thank you. Just checking.
Another question. My brother-in-law, who's not my brother-in-law anymore, but anyway, he engaged quite heavily in cannabis use from his youth and all the way through till like he's 40-some years old, and he started getting like really paranoid and stuff, and making really strange connections between and thinking people are out to get them and stuff like that. And then my mother was talking to a friend of hers who is a nurse, and she said, oh yeah, it's fairly common long-term marijuana use to end up with psychosis and different things. And so I'm wondering, why is that never talked about in any of the media about cannabis? There's these pretty huge long-term mental health concerns, and you never hear a sniff about it.
So that's a great question. And I'm actually going to preface my answer by going way back in my slides so that I have a little bit of context for you. Yeah. So your brain is continuing to develop, and CB1 is helping with that neural architecture. There's pretty consistent evidence, both in animal models and in the clinic, that if you add in extra cannabinoid during that early developmental window, that you can disrupt neuronal architecture. And some of that early adolescent use might be linked to the development of psychosomatic or psychological symptoms, whether they manifest as schizophrenia or depression. Now, that's not saying that the cannabis is causing those things. What it is probably doing is unmasking a predisposition to something that was already there. But it seems to be, based on the research that exists, that it's not necessarily long-term use per se, but it's long-term use that started early in life. So started early in adolescence. And so that seems to disrupt your neural architecture and have an effect on brain function long term.
It's interesting that like he seemed relatively normal. He was in his mid-30s, and all of a sudden he's just like this kind of downward trend. It's kind of strange.
Yeah, and I think to your second question about why we don't see that reported in the media, I don't have a direct answer to that, but I will say that there are really great resources, pointing to a few off of our own website, the Cannabinoid Research Initiative of Saskatchewan, as well as the McMaster University site. And then probably the best resource, I think, is from the Canadian Association for Mental Health, or CAMH. And they came out this year with what are called the Lower Use Risk Guidelines. And if you just Google those, they'll come right up. And they're written in a language that's accessible for teenagers specifically. And they're really helpful. And it's for anyone, but it's meant to be accessible. And just designed to say, like, these are actually the risks associated with early cannabis use and things that you should be aware of. So, yeah, I would encourage people to check those out.
That's great. Thank you so much. Can we a round of applause for Dr. Laprairie, please? Thank you. And thank you for rolling with the AV hiccups. So you're a seasoned professional. Thank you. Thank you so much. Okay, so I think lunch is on its way out now. And thank you for the continued questions. Just a reminder, as Dr. Laprairie mentioned, both he and members of his team are here throughout the day. So again, great appreciation is extended to the clinicians and researchers and students that are here with us for the majority of the day. Which brings me to my next point, is don't forget to mill through the interactive research clinic. Even if you're not participating or you don't wish to participate in the actual research piece today, make sure you stop and you check out the posters, the poster session with our students. These are our up-and-comers in MS research, so please thank them for their work, give them encouragement, and learn about the exciting things that they're doing, because there's some just absolute brilliant and talented people that are working for you, and they want to hear more about your journey as well. Again, a reminder, if you want to head over to the Interactive Research Clinic, you have the next hour to do so, and you can do just the consent piece if you want now, and then go back later and do the testing, or you can do it all in one foul swoop. That's up to you. There's also the resources at the back of the room that you can attend to as well. And I think I'm looking at the staff in the back of the room. Any other last-minute announcements? But I think otherwise it's let's roll into lunch. Enjoy.